The most important thing is to establish good ways to educate people, educate the patients. And this is difficult because there are barriers, so there are language barriers, and that's one thing. There's ethnic barriers, there are cultural barriers. The foundations can work very, very close to share information, but make it, find ways to deliver it to people in a way that helps them understand.
We create recently in Lupus Europe like a questionnaire that you can download in your own mobile or in your computer, and it's translated in many languages. And the purpose of that project is to teach the patients.
Our tribal nations have patients who have more severe disease, more vasculitis, and the most frustrating thing for them is that the textbooks were not necessarily written about their disease.
Lupus care is complicated because it's a chronic disease and the fact that the patients are really impacted in terms of their quality of life. They require a lot of time, and there's a lot of need that happens in between visits, whether it be how to get access to medication. We know that African Americans are more prone to getting lupus, and also, interestingly, less wanting to be involved with clinical trials. And so there's a lot of efforts to try to engage and explain why we need to do clinical trials, how it's highly controlled in all different kinds of regulatory ways so that the patient is protected. And so there's a lot of efforts to try to engage people who are from ethnic groups that are more prone.
So for me, in Canada, we have a special situation that I think is, I would say, unjust or suboptimal, and I don't think policymakers necessarily see that. So when I think of underserved people that maybe we need to reach more, I think about, there's different ways, right? There is education. There's also how to build trust, how to improve communication, and how to improve outcomes. I'll say race ethnicity is a factor, we know. And one of the reasons, it's not just your genetics, it's also your culture, who you trust. And in a way, it's also the demographics of our healthcare system. If everybody in the healthcare system is a certain color or race ethnicity, maybe it'll be a little harder to trust if you happen to come from another demographic. So the people who come to our clinic, great. The people who maybe don't come. We have people who have stopped coming to our clinic and we don't know. They have serious disease and we cannot find them. We cannot get them back to clinic.
There are a number of things. Number one is the demographics. We're dealing with young women in large part. 90% of lupus is in females, right? But it also occurs in children. So this is a young population. So we need them to understand that. We need the payers to understand also that preventative medicine, a word that you wisely used, in the long run saves money. You make an earlier diagnosis, you treat earlier, you're less likely to end up with the complications and the other forms of lupus that we talked about. So I think Canada's in a good position to do that, and I'm grateful. I stayed because in Canada because I think our healthcare system attracted me in large part to stay, because I could treat patients as I felt that they needed to be treated, not whether they could afford it or not.
The biggest problem are related to access to care. In our area, that's a big issue. Multi-pills that this patient had to take, most of the time, more than 20 pills per day, and this is a big problem.
I would say the most challenging thing as a clinician in the US is just getting the drug in the patient's hand. So we have a lot of insurance hurdles that get put up in front of us. Insurance companies dictate what drugs we have to use first and what we can use second. And even though we think drug X is the best one for our patient, we can't get to drug X until we've tried drug A, B, and C first. And so it takes a year to get a patient to the drug that we thought was going to be benefiting them at the beginning. So that's incredibly frustrating. And so it's frustrating for the patient. There are certain types of insurance in the US that are flat out won't provide coverage for certain types of medications. Luckily, the companies generally step in at that point. and try to help and provide patient assistance. But it's a lot of paperwork, a lot of nursing work, a lot of logistical hoops just to get a patient on a drug. So that I think is tough. So where I practice in Ann Arbor, we also have patients in Flint and Detroit. So certainly there's some underserved communities there that, you know, have delay in diagnosis, that systemic racism has contributed to, you know, their lack of access to care. You know, and there's socioeconomic factors that also play a role. If you don't have good food security, you can't eat healthy diet. If you know, are around, if you're in a family that smokes, it's hard to avoid smoke, even if you don't smoke yourself, right? If you live in a polluted area, you know, so there's pockets of places around Michigan where I live where these things are real factors.
I mean, lupus is a very diverse disease, and we know that access to care is also very different where you are in the world. I mean, some treatments may not be approved, or if they are approved, they may not be available, or they can be costly because the patients have to pay themselves for the treatment, which is a big challenge.
In terms of diagnosis, the real message is to educate the first sort of people that interact with a potential lupus patient, the primary care physician, the family physician. For women, a lot of times it might be the OBGYN physician that they see to say, hey, something's a little bit amiss and maybe this could be an autoimmune disease. The stories I hear, and you probably have the same stories, is that a person who eventually is diagnosed with lupus will have seen several physicians and sort of not necessarily not taken seriously, but they've tried to put this together as something else. But when you have a constellation, I like to say when you have a constellation of symptoms that don't seem to make sense and aren't easy to put together, you should think about an autoimmune disease.
I would say that the awareness is now increasing and that we are able to identify patients at an early stage, and hopefully we are not delaying the diagnosis, the journey that patients go through, sometimes years, until they get a diagnosis for lupus. So I would say that I'm more enthusiastic about the early phase, that we as clinicians are able to identify the patients at an earlier phase, and hopefully we can treat them earlier and in the long run.
Mental health is one of the aspects of the disease that has been more or less overseen or neglected in the previous years, and we tend to realize this now very, very well.
We as physicians, we are learning more. We are learning more how to treat our patients, how to couple with them about what the disease and how this disease is affecting them mentally.
For many of my patients, whenever they're first diagnosed with lupus, they go home and they read on the internet all the things about lupus, which is a scary thing to do. Please don't do that. Lupus can affect your brain directly. In addition, lupus causes a lot of challenges for our patients with other mental health issues. And lupus also is associated with chronic pain and with the difficulty of never knowing from day to day what lupus is going to be like.
Patients tend to complain a lot about these kinds of symptoms. So difficulty concentrating, difficulty sleeping. It's important to recognize it and sometimes ask the proper help from other disciplines.
I'll be very modest because I think we are not doing well. First, the access to psychological care is really limited in France because psychologists are a rare species. I mean, we don't have so many psychologists. And when we have psychologists, usually they are not really trained in chronic diseases, which is something very different from other situations. It's not like the burden of harassment or something, it's very specific. And we don't really have this expertise.
And that's also a very important thing to discuss, is that men feel alone. That's what they say. I talk a lot with men with diagnosed with lupus, and that's what they say. I feel alone. I don't have anyone to talk about. And when they go to, for example, the groups, the patients groups, it's 1 man, 10 women. And when they're in safe environments, they share with me that in those groups sometimes they don't dare to say what they really are experiencing, to share their questions. They don't have anyone to spare with. So that's definitely a problem that we need to tackle. But yesterday also for me was a very touching experience.
Oh, that's great.
Because there was not a lot of people, but the patients who were there were men. And in the end, all of them approached me and said, you know, I've been struggling with this. I've been diagnosed 20 years ago, and I always had questions, but I never asked. Nobody ever discussed this with me.
The other thing that we've been focusing on in our lupus program in Michigan is really trying to augment, the standard, like take your medicines, get your labs kind of care with alternative therapies as well. So we're doing a lot of clinical trials and things like yoga, ways to treat chronic pain. We've developed a website called Conquer Lupus, which uses a lot of the data that comes from our really outstanding pain research center at the University of Michigan to help patients with self-care and management of their lupus symptoms. So we have, videos on nutrition and exercise and sleep and all the things that we know are beneficial to help patients, deal with everything with lupus. It's not just about taking your meds, but it's about, kind of modifying everything to try to keep your body as happy as possible. So we've provided some of those resources.
The one area in lupus that's still not been thoroughly investigated enough is central nervous system lupus. And why is that? Well, we can't biopsy the brain like we can biopsy a kidney, but we're getting much better at imaging now and all kinds of cognitive testing. And I think that a number of centers, and our center in Toronto under Dr. Tuma right now, are delving deeply into the cognitive changes, the central nervous system changes. I think that's an area that is beginning to be investigated. I think we're going to see significant changes in that over time. The poor patients with central nervous system lupus aren't even eligible for most drug trials. So I think that's going to change.
Yeah, we've done studies with quality of life in patients with cutaneous lupus. There's no question that there's a huge impairment. And in fact, if you use some tools that are used to compare diseases, sometimes in some of the emotional and mental health areas, they're doing worse than people who've had recent heart attacks or have serious medical conditions like type 2 diabetes. It really has such an impact because people really feel that they look so different and they're unable to really engage in the outside world in a way that they would like to.
Fortunately, the treatments we give for lupus can also impact on the mental health. Some treatments can cause depression, others may cause difficulty with wakefulness. And we have to always try to find the best treatment for each individual person. Now there's where I am very optimistic because so many new treatments are in development. We'll have more choices and better choices in the future for the patient. It's also quite understandable that a person who has to deal with a lifelong disease with an unpredictable character, with many complex issues that are not always recognized so well in the healthcare system, that they could feel a bit lonely and isolated. What we try to do in Amsterdam is to have a very frequent contact with the patients, also through physicians but also through nurses who are trained in rheumatology and knowledgeable. We work together with other specialty disciplines and we try to also provide access to the mental health care facilities that do exist.